Good morning and welcome to this meeting of the Midwest Comparative Effectiveness Public Advisory Council. Today's topic will be sotatercept for pulmonary arterial hypertension effectiveness and value. We'll be letting people join the call over the next minute, and we'll be getting started very shortly.
Hello and welcome everyone. My name is Reem Mustafa and I will be chairing this public meeting today. I am a professor of medicine at the University of Kansas Medical Center, and I direct the Outcome and Implementation Research Unit there. And I do not have any updates to my conflict of interest. I would like to welcome you all, and we're going to start by asking the Midwest CEPAC members to introduce themselves and let us know if they have any updates to their conflict of interest, which is something that we're going to ask all the speakers and panelists to do today. I'm going to start by Dr. Bijan Bora.
Yeah, hi everyone. Good morning. I'm Bijan Bora. I'm a professor of health services research at the Mayo Clinic College of Medicine, and I have no updates to the conflict of interest that was reported earlier.
Great. Welcome. Dr. Aaron Carroll.
Good morning, everyone. I'm Aaron Carroll. I'm a professor of pediatrics and chief health officer at Indiana University, and I have no updates to my conflicts of interest report.
Great. Welcome. Dr. Don Casey.
Hi, good morning. I'm Dr. Don Casey, Associate Professor of Internal Medicine at Rush Medical College, Rush University in Chicago. No updates to my disclosures, and I have no disclosures. I have no conflict, so thank you.
Thank you. Dr. Greg Kerfman.
Good morning. My name is Greg Kerfman. I'm the executive editor of JEMA, and I have no updates.
Thank you. Dr. Stacy Tusetsina.
Good morning, everyone. Stacy Tusetsina, Professor of Health Policy at Vanderbilt University Medical Center, and I have no updates to my conflicts and no relevant conflicts for this.
Great. Dr. Ingve Falkjader.
Yeah, hi, I'm Ingve Falkjader, Professor of Medicine at Case Western Reserve University, and I have no conflicts of interest. Thank you.
Ms. Heather Guidon.
Good morning, Heather Guidon. I'm a board-certified healthcare advocate and the program director of the CEC in Atlanta. I have no disclosures and no COI.
Great, welcome. Dr. Jill Johnson.
Good morning. My name is Jill Johnson. I'm a clinical pharmacist and professor at the University of Arkansas for Medical Sciences College of Pharmacy, and I have no updates to my disclosure. Thank you.
Great, welcome. Dr. Bradley Martin.
Good morning. I also work with Jill at the University of Arkansas for Medical Sciences, but in the Division of Pharmaceutical Evaluation and Policy. I have no relevant conflicts or updates.
Great. And Dr. Kurt Bach.
Hi, good morning. My name is Kurt Vandenbosch. I'm a pharmacist with the St. Luke's Health System in Twin Falls, Idaho, and no updates to my conflicts of interest.
Great. And Dr. Stuart Winston.
Good morning. I'm a cardiac electrophysiologist, clinically retired, lead patient experience consultant for a large multi-specialty group in Southeast Michigan, Trinity Health.
Great.
And I have no updates to my conflicts of interest.
Welcome. And I believe last person from the Midwest CEPAC is Dr. Alan Balk.
Welch, I'm the CEO of the National Patient Advocate Foundation. I have no updates to my conflicts of interest. Thank you.
Great. Well, welcome everyone. And with that, we would like to introduce some of the patients and clinical experts who are with us today. From the patient experts, we have Julia Fietner.
Good morning. Yes. Pleased to be with you. My name is Julia Feitner. When I was diagnosed 15 years ago, I was the mom of a 3-year-old and pregnant with our second son. And I've been fortunate to be in the life-altering sotatercept trial the past several years. And I have no updates to my disclosure.
Thank you so much for being with us, Julia. And we appreciate the perspective and input that we're going to hear from you. We also have Katie Kroner.
Thank you, everybody. Katie Kroner, I'm the Vice President of Advocacy and Patient Engagement at the Pulmonary Hypertension Association. I do not live with pulmonary hypertension myself, but I've worked with PHA for 18 years and had a great opportunity to get to know a lot about the disease and connect with the community. I don't have any updates to my conflict of interest.
And thank you so much, Katie, for being with us and representing the patient voice. Thanks. And we have 2 clinical experts who are going to be with us today. Dr. Levine is going to join us later. And we have Dr. Mark Simon.
Hello, Mark Simon, Professor of Medicine and Director of the Pulmonary Hypertension Center at University of California, San Francisco. It's lovely to be here. No updates to my conflicts.
Great. And thanks, Dr. Simon, for being with us today. Thanks, everyone. And I'm going to ask and remind everybody throughout the day to always remind us of their conflict, if they have any, as they present their views. With that, I would like to hand it to Dr. Steve Pearson, President of ICER, who will take us through some introduction.
Thank you, Reem, and good morning again to everybody. And thank you both for past services rendered and for today and ongoing, our patient experts and clinical experts. Thank you again. So let's start with why we're here today as an introduction to our meeting. We always want to start with the view from the patient experience. And obviously there's not one patient experience, but here's a quote that I think captures important elements. I was diagnosed with pulmonary arterial hypertension about 8 years ago. At the time, the statistics showed, on average, patients lived about 3 to 5 years after diagnosis. As you might imagine, this kind of news radically changes your life. Not only was I trying to learn about the disease I have, manage the plethora of treatment steps, as well as deal with the basics of everyday life, but I was also trying to wrap my head around the idea I could die in the next few years. It was a terribly scary time, and at times still is. As a result of pulmonary hypertension, I've given up and lost many things. Sometimes I'm sad and long for when I was normal. Other times, however, I see in the midst of loss, I've gained so much, including an incredible appreciation for life. And this is from a person living with pulmonary hypertension, Nicole Du Temple Nichols. And there's the source if you'd like to see it. So what, among the many things that you can capture from that very rich quote, is the unmet need. It's the impact of this condition on people's lives, not just their health, but their lives. And so we're going to be trying to keep a broad view on all of the effects of potential treatments for people and their families living with pulmonary hypertension. There are multiple reasons why we're here today, because we are probably in the somewhat of a run-up to a likely FDA approval for a new treatment for pulmonary hypertension. And what happens the very day that these treatments receive approval is an expected and very welcomed sense of celebration. Years of research, years of input and engagement from the patient community, clinical leaders, experts, the companies that invest, take risk, and design the trials. All of that culminates in a sense that we have something new that patients and families can potentially benefit from. So that's a very exciting sense. Other things happen that same day, including usually around that time, the company will name a price And a whole host of other questions continue to be relevant. Because even though the FDA might have said yes, there are still going to be questions about the risks and benefits for particular patients who may not look exactly like the average patient in the clinical trials. There are broader questions about whether the treatment fits, where it fits into the evolving treatment landscape. Is it the first drug that should be used? Is it the last drug that should be used? How does the decision-making around that work? Tied into some of those questions are additional questions about the pricing and the costs to patients themselves, what they have to pay out of pocket and in their insurance premiums, but also broadly to the health system, the government that's a major payer, and to our broader society. And we're always looking for lessons about, what worked well in the innovation pipeline to get a new treatment available to patients. But what also could we learn to do better about this drug in the future or other drugs as they come into practice around ways that we learn about their relative benefits for different kinds of patients, make sure that the pricing aligns with those benefits and can lead to an overall ecosystem that supports innovation, but also access in a way that works for everybody. And that working for everybody is important because that's a key reason that we are here today. Healthcare costs are going up, and they will continue to go up as we add new treatments. Very rarely do they actually save money in the long term overall. We're usually getting better health from additional costs, but those additional costs have their own impact on people. So we'll be talking about patients and families, people living with pulmonary hypertension, but it's important to keep our eye, if you will, on other people as well. Sorry for the glitch there. And one way to do that, I found in this article about a survey from the Kaiser Family Foundation last year, in which they sampled a random sample of Americans and found that by extrapolation out of our entire population in America, over 300 million, 100 million Americans are living in medical debt today. That means that they can't pay off the medical expenses that they have. They have health insurance, but they were also trying to wrestle with the out-of-pocket costs. There are other Americans, not even pictured here or in this survey, who have felt that the cost of health insurance itself are such that they can't afford it, even with potential subsidies. They don't qualify for Medicaid. There's still a gap in which millions of Americans feel like healthcare itself is unaffordable. The families here, the wards on the left with their children, the children were born prematurely, described in this article, and they went to, they had to have special treatment options that were not covered well by their insurance. They ended up in medical debt, had to change jobs, move to live with family, really disrupted their entire lives. And the survey, by the way, found that among the people with medical debt, imagine 100 million Americans, 63% of them felt that they had to give up food, rent, utilities, that they'd had to really try to balance other things, and that they were in debt not just on medical, but on other expenses as well. Sam and Ariane Buck, the couple in the middle, ironically, his job was to call people and to work with them to enroll them in Medicare Advantage plans to get insurance. His own insurance in that job left him vulnerable when he went to the emergency room and ended up with procedures that required him and his wife to go into bankruptcy. Similarly, Sherry Foy, the woman on the far right, she and her husband also had to go into medical bankruptcy when her insurance left her with very high out-of-pocket costs. So obviously, a new drug coming in to care is not by itself the domino that's going to lead to a lot of bad things downstream, but it's the effort that we all have to take to view this broader landscape of people, because in the meeting today, we are going to keep our eye firmly on the patients and families with pulmonary hypertension. But in doing so, we are not going to forget that around them, around all of us, are other families, other patients with their own healthcare needs, their own hopes for future treatment, and everybody's ability to try to afford that needs to be viewed as part of a common effort among all of us. So if we can keep that broader view in mind, as well as our focus on learning about and celebrating the innovation for patients with pulmonary hypertension. That will be our goal for today. So in the meeting today, you've already been introduced to the members of the Midwest CEPAC. Let me do a brief overview of ICER, the convening host for this meeting. Our own financial conflicts of interest, I suppose, potential conflicts of interest. We keep our revenue sources updated on our website. And as you can see, about 67% come from nonprofit foundations. None of them are directly from payers or from life science companies. The biggest one of those foundations is the Laura and John Arnold Foundation. There are many others. We have smaller slices from ICER Analytics. That's our cloud-based platform of our work, individual philanthropy. And about 22% overall do come from health plans and provider groups at 8% or life science companies at 14%. But that is sequestered aside for a policy summit program that does not feed into the research or the work done for these meetings. So the report that is, if you will, the kind of foundation of the discussion today is developed over about an 8-month period. And it starts with a very intensive phase that we call scoping. And that's where we reach out to patients and patient groups, to clinical experts, the manufacturers involved, and other stakeholders to really try to get oriented around what the key questions are, what is the lived experience of patients with this condition and how a new treatment might influence that. We need to get grounded in that North Star of the lived experience in order to do justice to the evaluation of the evidence that we will then pursue. So following that, we do our internal work on the evidence, looking not just at published research, but whatever we can get from the manufacturer, sometimes from patient groups if they have patient-reported outcomes, or other ways that we can complement the research to try to get as broad a view of the evidence as possible. And we do a cost-effectiveness model that you will be hearing about today as a part of looking at the long-term value based on the shorter-term data that we have. Our reports go through several different cycles of public comment and revision, and we were fortunate to have specific expert reviewers give us feedback, including the folks listed there, 2 of whom are with us on our policy roundtable. So the report itself, it's structured in a way that's meant to support the discussion today, but it culminates, if you will, in a view of what value is. And so we call it our value assessment framework, which is sometimes kind of peeking towards a question about what is the long-term value of a new treatment for the money, for the cost of that treatment. So to get a broad view at that, we have to look at different kind of categories of information. So the report will always look for evidence and try to understand whether a treatment at the bottom here could lead to or has demonstrated its ability to produce longer life. Some treatments do, some treatments don't. And in addition to that, though, many treatments will improve our health by helping us return to function, have fewer side effects than other treatments, etc. And when we're talking about the cost or the money, we are looking at the overall cost, not just the drug cost. So we're trying to see if an expensive drug might, at least in some way, prevent additional costs by keeping people healthier, leading to fewer hospital visits, fewer needs for other expensive treatments, etc. So that's in the green box is kind of, if you will, the data-oriented part that is sometimes easier to get a handle on. But we also want to make sure that we are keeping our broader view on things that we call benefits beyond health or special social and ethical priorities. And you'll see specific discussion and votes on these, but they relate to our general sense of whether the condition is extremely serious and has a short-term risk of death. Perhaps there are equity issues involved with this treatment or this condition that we want to keep our eyes on. And we want to make sure that we talk about the effects on families and caregivers and others, even if we don't have specific data on that from clinical trials. So all of that is part of the report and will be part of our discussion today. We'll start off with a presentation from the lead kind of scientists in our team on the clinical evidence and the economic model. We'll have a public comment and discussion phase, followed by lunch. Coming back, we will have further deliberation by the CEPAC, and they will take their votes on the evidence. And then the day's meeting concludes with a policy roundtable that will start at 2 o'clock Central Time, in which our patient experts, clinical experts, will be joined by representatives from the payer community, and we'll talk a lot about how this evidence gets translated going forward into the way that clinicians will treat patients, to the way that insurance will cover it. We will talk about pricing and other aspects as well. So with that, let me introduce the next presenter, Dr. Grace Lin, who will give us the overview of the evidence on clinical effectiveness. Grace?
Thank you, Steve. Next slide, please. This presentation and the report have been put together by myself and the outstanding research team at ICER, Dimitri Nidekin and Emily Nan, and our disclosures are listed on this slide. Next slide, please. So let's talk a little bit about pulmonary arterial hypertension, or PAH, in terms of some background. PAH is a type of pulmonary hypertension where there's high blood pressure in the arteries carrying blood from the right side of the heart to the lungs. As the pressures in the arteries increase, the heart has increasing difficulty pumping blood to the lungs, and this leads to symptoms like dyspnea, fatigue, chest pain, and cognitive difficulties. PAH is a progressive disease and eventually can lead to right-sided heart failure. This disease also significantly shortens the lifespan for most patients. About 1 in 5 patients with PAH die within 3 years of diagnosis, and about 40% die within 5 years. PAH has a variety of causes. Most commonly, the disease is idiopathic, meaning there's no known underlying cause that we can detect with current methods. There's also some genetic mutations that can lead to PAH. And people with connective tissue diseases like systemic sclerosis are also at higher risk of developing PAH, as are people with congenital heart disease and HIV, for example. Finally, there's a growing population of patients who develop PAH due to drugs, either as a side effect of a medication like a chemotherapy medication or use of drugs like methamphetamine. Around 50,000 Americans are affected with PAH, which makes this a fairly rare disease. It does affect women more than men, and it's typically a disease of onset that has onset in the younger ages between 30 and 60 years old. It's also, as you can imagine, a very expensive disease with annual medical costs running above $100,000 per person. Next slide, please. The severity of the disease, or one of the ways we can measure severity of PAH, is through the World Health Organization functional class system. You can see here in the schematic, the system is based on a person's symptoms and their ability to do normal tasks. So people who are asymptomatic are considered class 1, and then as their symptoms progress and they begin to have more and more discomfort with normal tasks, they progress into higher WHO functional classes. And the most severe disease is WHO functional class 4, where people have symptoms at rest and their symptoms get even worse with normal tasks, and they, in some cases, can't even do normal tasks because of their symptoms. Next slide, please. There's currently no cure for PAH other than lung or heart-lung transplantation, so the goals of therapy are to slow disease progression and improve symptoms. Medications that are currently available to treat PAH promote vasodilation through various mechanisms. The first-line therapy is combination of a phosphodiesterase inhibitor and an endothelin receptor antagonist, and that's called dual therapy. In some patients, either patients who have more severe disease like diagnosis or who progress on dual therapy, there might be the addition of other agents such as selexipag or prostacyclin analog. These medications come in various formulations. Some are oral, some can be inhaled, subcutaneous, and intravenous. In terms of the intravenous medications, those often need to be infused around the clock. So people will have a catheter placed to allow that to happen. As I mentioned earlier, lung and heart-lung transplant can be considered, but given the scarcity of organs, most patients don't end up with a transplant. Next slide, please. We were fortunate to have several persons living with PAH share their experience with us. During these interviews, we learned that PAH symptoms can cause significant disruptions to life. People with PAH spoke about how their symptoms hinder their daily activities and lead to the reduction or the loss of activities that they previously enjoyed. We heard that it can be very difficult to make plans for activities since people don't know whether they may be having a bad symptom day where they just really can't accomplish what they had intended to accomplish. Many people end up leaving the workforce prematurely due to symptoms. Sometimes they have to move to a lower elevation to help relieve their symptoms, and it can also alter their plans for a family. As you can imagine, PAH has a high caregiving burden, as patients often need to rely on family members for their daily activities that they're too symptomatic to complete. There's also a high treatment burden. The oral and inhaled versions of medications often need to be taken several times a day, and as I mentioned, the infused therapy can require around-the-clock administration. We also heard that access to PAH therapies can be difficult due to high costs, due to barriers to insurance coverage, and challenges with medication administration. For example, if you have the infusion, you can't go, even a few hours without your infusion, and so you have to make sure that you coordinate delivery so that you don't run out of your medication. As a result, patients expressed hope for more user-friendly treatments in the future. Next slide, please. So the main topic today is sotatercept. It's a new therapy that's currently under review by the FDA. It is an activin signaling inhibitor, and it may affect vascular remodeling by blocking abnormal signaling between cells. It does reduce pulmonary vascular resistance, improving blood flow, and because of this potentially this different mechanism of action, it's thought to be potentially disease modifying. This is a drug that's delivered subcutaneously every 3 weeks. And it is a decision about whether to approve sotatercept is expected by next March. Next slide, please. So in this review, we'll be talking about adult patients with PAH who are in WHO functional class 2 or 3 who are on stable background therapy. And stable background therapy includes those classes of drugs that I mentioned previously, either dual therapy or triple therapy. And we are comparing sotatercept to that standard of care PAH therapy. Next slide, please. Next slide. So in terms of the clinical evidence we reviewed, the key clinical trial is a phase 3 trial called STELLAR. Next slide. This is a phase 3 double-blind placebo-controlled randomized trial of approximately 300, a little more over 300 patients, and it lasted for 24 weeks as follow-up. Next. Here, the mean age is around 48, and people had PAH for almost 9 years when they were, on average, when they were enrolled in the trial. Next. You can see that most of the people in the trial had idiopathic PAH. Of note here, you can see that a minority of people had connective tissue disease associated PAH or drug or toxin induced PAH. And next slide, please. And as I mentioned, these are class 2 and class 3 WHO functional class on dual and triple therapy. Next. We also looked at 2 long-term extension trials, a phase 2 Pulsar trial, which had 18 to 24-month open label follow-up, and Soteria, which is a phase 3 open label long-term follow-up study that's ongoing, but there was data from 1 year of follow-up. Next slide, please. So in terms of sotatercept, the sotatercept treatment with sotatercept improved functional status. The primary outcome of the STELLAR trial is the 6-minute walk distance, which is a standardized way to measure how a person with PAH, how far a person with PAH can walk in 6 minutes. After 24 weeks of treatments, participants in the sotatercept group were able to walk 40 more meters than the placebo group. This effect is clinically significant as the estimated minimum clinically important difference for the 6-minute walk distance is estimated to be around 33 meters. This improvement in 6-minute walk distance was consistent across most subgroups. Almost 1/3 of patients in the sotatercept group had improvement in their WHO functional classification, meaning they moved to a lower severity, for example, from class 3 to class 2 or class 2 to class 1, and compared to 14% in the comparison group, and this was also statistically significant. Next slide, please. One of the secondary outcomes was the risk of clinical worsening, and this is a multi-component endpoint that included the first fatal or non-fatal clinical worsening event, such as a worsening of PAH, an increase in the prostacyclin dose would be examples of the non-fatal clinical events. Here, the sotatercept group had an 84% decrease in the time to the first occurrence of a clinical worsening event. The majority of the events in the sotatercept group were related to worsening of PAH or the need to need to initiate or increase intravenous prostacyclin therapy. There were very few deaths in either group. There are, I think, 8 deaths total in the clinical trial, mostly in the placebo group. Next slide, please. Another secondary endpoint was the improvement in a separate multi-component endpoint, which included 6-minute walk distance, a biomarker called NT-proBNP that can be associated, that's associated with severity of PAH, and WHO functional class. This again was in favor of the sotatercept group. Almost 40% of patients in the sotatercept group achieve this improvement in this endpoint versus 10% in the placebo group. When looking at other biomarker and hemodynamic endpoints, the sotatercept treated group also had larger improvements, for example, in pulmonary vascular resistance or mean pulmonary arterial pressure, NT-proBNP versus the placebo group. There was no change in overall quality of life on this quality of life measure called the PAH CEPAC, which is a 23-item patient-reported quality of life scale that's specific to PAH. There are 3 domains measured by the scale: physical impact, cardiopulmonary symptoms, and cognitive and emotional burden. After 24 weeks, again, there was no overall change in quality of life, but when you look at the subdomain scores, there was greater improvement in the cardiopulmonary and physical impacts subdomains in the sotatercept group, and no difference in the cognitive emotional impacts. Next slide, please. In terms of durability of treatment effect, we drew upon results from the phase 2 Pulsar open label extension study and the Soteria phase 3 extension study. In the Pulsar open label study, the maintenance of benefit in outcomes such as 6-minute walk distance, NT-proBNP, WHO functional class was seen up to 18 to 24 months. There was also the similar results were seen in the Soteria trial. Now that trial is ongoing. It's scheduled to last for 7 years, but there's interim data that was released for 1-year follow-up. And again, there was maintenance of treatment benefit in the 6-minute walk distance, NT-proBNP, and the WHO functional class at 1 year. Few patients, less than 2% in the Soteria study, have experienced clinical worsening so far. Next slide, please. In terms of harms, sotatercept was very well tolerated. In fact, there were fewer serious adverse events in the sotatercept group versus the placebo group, and there were no deaths related to adverse events recorded. There was very low treatment-related discontinuation, less than 2%. There are some adverse events of special interest because of the mechanism of action of sotatercept, and these included increased hemoglobin, telangiectasias, which are also called, you might hear of them as spider veins, and bleeding events, most of which did not require hospitalization. In the Soteria trial with 1-year safety events, they look fairly similar to the Stellar trial with few adverse events or discontinuations. I will note that there were 4 recorded deaths in the SOTERIA trial, although details of those deaths have not been released, so we don't know whether these are related to sotatercept treatment or not. Next slide, please. As always, there are some uncertainties in the data. As you may recall from the characteristics of the trial population, there are relatively few patients with connective tissue disease, which is an important subpopulation because historically these patients don't do as well on standard PH therapy. The connective tissue disease patients also have already have a risk of developing telangiectasias, which may bleed. So the fact that treatment with sotatercept may increase that risk is an important thing to keep in mind. There were also relatively few patients with congenital heart-associated disease PH and drug-induced PH, which are growing populations. Although the STELLAR trial looked at composite endpoint of clinical worsening and death, it wasn't powered to examine mortality separately. So we don't know what its impact on mortality alone is. This is important potentially because multi-component endpoints can be heavily influenced by 1 or 2 of the outcomes in the multi-component endpoint and obscure other important events. More data are also needed to determine if this sotatercept is truly disease modifying, whether it can be discontinued after a period of treatment and is effective in more severe or newly diagnosed patients. There are some ongoing trials to try to provide answers to some of those questions in the future. Next slide, please. There are some potential other benefits and contextual considerations. PH is severe and affects younger people, and so effective therapy could have a significant impact on patient and caregiver abilities to achieve major life goals. Since this is sotatercept is a subcutaneous injection given once every 3 weeks, in some patients, this could simplify the treatment regimen, particularly if it prevents or delays the need for infused therapy. And then treatment that's less complex and well-tolerated could decrease some health inequities and outcomes in access due to age, limited social support, or socioeconomic status. Next slide, please. We appreciate the comments we received on a report. We received a comment that sotatercept may displace other therapies in the treatment algorithm, and thus we should consider an active comparator such as CEPAC. However, in discussion with clinical experts, there appeared to be a lot of variation in how and when CEPAC is used, and sotatercept in the clinical trial was tested as an add-on 3rd or 4th line therapy, so we didn't review sotatercept in the context of displacing other PH therapies. Next slide, please. So in summary, treatment with sotatercept improved 6-minute walk distance, WHO functional class, and hemodynamic endpoints, and also decreased the risk of clinical worsening of PAH. Some early limited extension studies suggest maintenance of treatment benefit beyond the 24-week timeframe of the phase 3 trial. The impact on mortality remains uncertain, and sotatercept has high tolerability, and the overall safety profile is promising. Next slide, please. So based on the evidence I presented, we felt that sotatercept likely had at least a small, but may have up to a substantial net health benefit, with some remaining uncertainty about the durability of the improvements, its impact on mortality, and unknown future harms, since this is a drug with a new mechanism of action. So as a result, we gave sotatercept a B+ rating, which corresponds to an incremental or better improvement over current therapies. Next slide, please. And I'm happy to take questions at this point.
Well, thank you so much, Dr. Lin, for this really excellent presentation. And thanks to the Midwest CEPAC members who already have their hands up. So we're going to start with questions. I think first is Dr. Kerfman.
Yes, thank you very much, Reem. I have a comment about the STELLAR trial. And the primary endpoint, as you indicated, Dr. Lin, was the 6-minute walk distance. And the change in 6-minute walk distance in the active treatment group was 34.4 meters. And you indicated that the minimal clinically important difference was just about that. And so that was a median value. So that tells us that half the patients had less than a clinically important improvement in the 6-minute walk distance. So I think it's just important to keep this interpretation in mind. Half the patients did improve beyond a minimal clinically important difference, but half did not. And so I think that's the perspective that we should be putting the primary endpoint of the trial. It's the primary endpoint. We should be putting that in perspective. Thank you.
Thanks, Dr. Kerfman. And there are, yes, you are correct in that this is a median change. What I had in my presentation, actually, there are two different results of the 6-minute walk distance reported in the trial. The 33 meters or 34 meters is the absolute difference between groups. They also calculated what's called a Hodgins-Lehmann difference that's required by the FDA. And that's to account for some differences in the trial groups, and that was 40 meters. But regardless, I think, and I just wanted to point that out to avoid confusion of why we might be quoting different numbers. But regardless, I appreciate your comment about yes, since this is a median difference, not everybody had a clinically important change in their 6-minute walk distance.
Thank you. Dr. Citizina.
Thank you so much. That's an excellent presentation and work. Dr. Lin, I wondered about the number of years that people had PAH in the trial you mentioned was over 8, and that there were going to be more studies, or there are ongoing studies for people earlier in diagnosis. And I wondered if you could just speak to what you might expect that to mean for the results we're looking at. Would there be more or less benefit if someone were enrolled or were taking the therapy earlier, recognizing the evidence is still accruing?
Yes, thank you for that question. I'll answer briefly, and then I'll ask our clinical expert also to weigh in. I think, the main question that I think you're getting at is this a disease-modifying treatment? Meaning, if we put people on this earlier, will we, slow down progression or even stop progression and prevent people? And I think that's a hard question to answer because the trial was 24 weeks, so we can't really know whether it's disease modifying. I think the mechanism, if it's indeed true that that you affect remodeling of the arteries, this could certainly lead to disease modification. But I think it's hard to, I think whether or not this is going to be true, we need to wait for longer term studies. And I'll ask Dr. Simon also if he has any comments on that.
So in terms of outcomes, it's very hard to get long-term data on such a small patient population as pulmonary arterial hypertension. There's really only been very few trials so far that have done this. The Griffin trial that for CEPAC did this, and one other. So the fact that we even have this data is pretty impressive, and that it is in parallel with all the other surrogate endpoints for outcomes. We feel pretty, I would say, in the community, feel pretty optimistic about. Having said that, the point is very well taken, and it will require some form of longer term studies to really know that in terms of outcomes. I'd like to make one other comment about the 6-minute walk comment.
Yes, go ahead, Dr. Simon.
That clinically meaningful number of about a little over 30 meters is derived from one study that looked at a bunch of FDA registry trial data. And so it fits with what we think of as a clinically meaningful change in 6-minute walk distance, 30 meters. But I feel personally at least a little bit of hesitation, knowing for certain where to place that value. I think it's also good to realize, look back at other pulmonary arterial hypertension trials for drugs that have been approved and where that 6-minute walk metric has been. So if we look at the Griffin trial upon which selexipag was approved, there was a 12-meter walk increase. If we look at the Ambition trial, which was sort of the seminal trial of combination therapy with ambrisentan and tadalafil, that forms the basis of our first-line treatment right now. There was a difference of about 25 meters. And you can go through the trials and find a range that is about 30 meters, or in some cases even less. And so I think that's just important to keep in mind. And with those drugs, we've, in the end, we've seen over time improvements in outcomes.
Great. Thank you. Dr. Falkjaer.
Yeah, thank you. Just in the same vein, I think, I'm sorry, I didn't see this on the slide, but you might mention it, so I apologize. What was the average starting point severity of the 6-minute walk test? And was there a difference how people responded depending on their initial severity?
400 meters starting.
400. Okay, thanks. And was there differences in those who were started out? There was probably a spectrum of disease severity. And were there a differential in how they responded?
Yeah, there was obviously a spectrum, but we don't have they don't report sort of individual patient data, so we don't know that the answer to that question.
Right, because prior, therapy has shown to be sensitive to the baseline severity. Thank you.
Thanks, Ingva. I'm going to go next, and I see multiple other hands. My point is actually partly a follow-up on Dr. Simon, your comment related in comparison to other treatments. But something is obvious. This has been reported as a median, and one can ask themselves why not a mean, which tells us that there is that the data was skewed one way or the other. And I just heard you, Dr. Lynn, say, we don't have the individual data, so sometimes hard to make comments. I don't know if either you or Dr. Simon have any thoughts about, why a median and how could that have affected our results? So that's the first point. And the second point I wanted to ask about is, with that clinical improvement, I was, questioning if you have any thoughts. There was no improvement in quality of life, a validated tool specifically developed for patients with PAH. And is it fair to say that that was mostly driven by the fact that there wasn't as much improvement in the cognitive and emotional part of the scale, and that most of the improvement we see on the functional part? Any thoughts about that? Thank you.
Thank you, Dr. Mustafa. I will answer the second part of your question. Yes, so the lack of improvement in the PH SYMPACT overall score was driven primarily by no improvement in the cognitive emotional impact scale. The PH SYMPACT, as you mentioned, was developed specifically for PH patients, but it, from what we understand, and Dr. Simon can comment on this more, from discussion with our clinical experts, it's pretty hard to show improvement in quality of life overall, and it's not entirely clear why. So it's hard to know what to make of these quality of life results.
Thanks. And Dr. Simon, any thoughts about that and the median issue?
Yeah, the median issue is very interesting. You raise a very good point. I don't know what to say in terms of statistically. I think there's others here probably better poised to answer that than myself. But you raise a very good point. Using the median reflects a likely skew in the data. One observation I have, I think was brought up, the baseline 6-minute walk distance of 400 meters is actually, in my opinion, pretty good for these patients. And so it strikes me that starting at that point makes it even harder to see a signal a lot of times. And so the fact that there is one, to me, that kind of strengthens the fact that it seems to be a pretty reasonable, from a clinical perspective, signal. If we look back at, for example, the Ambition trial, the mean 6-minute walk distance was about 350 meters. And I think that probably reflects the fact that patients were actually on triple therapy in large part, a large percentage of patients. So the effect being on top of multiple therapies at this point, which is typically how we study new drugs. So I'll stop there.
Just so we don't get too caught up on the median, our research team has been pointing out in the background that the mean difference is very similar to the median difference in this trial. So it too is around 40 or 41 meters mean difference.
Great. Thanks, David. David, I see Dr. Winston, hands up.
Yes, I was struck by a piece of information that came from the Pulsar drug extension trial, where the percentage of functional class 1 rose from 7.5%, which was recorded at the end of the trial, and rose to 20.6 at the end of the open label. I'm wondering, should we see that as a signal of disease modification, or is there an analogous improvement in other therapies other than sotatercept?
I'll jump in real quickly. I think that's a remarkable piece of data you point out. I don't recall seeing that in any other open label, that much of an improvement in functional class 1, right? Getting to our best functional status.
Great. Thank you. Dr. Casey.
Thanks, Reem. And Dr. Lin, thanks to you and your team for a great evidence review. I have one quick question and then a follow-up on exercise that I posed to the clinical experts before. The first question relates to, maybe for Dr. Simon, your thoughts about the presence of telangiectasia during the study in about 5 times the number of patients, i.e. 10%, as opposed to 2% or so in the control group. I mean, theoretically, I guess this is supposed to be focused on TGF-beta receptors and is associated with hereditary hemorrhagic telangiectasia as well. So I wonder if that's what that's saying to you, i.e. perhaps maybe there's a dose benefit effect, perhaps, I don't know, but it seems like an adverse sign. And then the second part is really following to our discussion, Dr. Lin, maybe you know, it doesn't appear that in addition to the 6-minute walk test results, that we had information on what the exercise habits were of these patients. And looking into the 2022 ESC pulmonary group guidelines, that's now in guideline terminology 1A. Obviously, we spoke about the presence of formal pulmonary rehab, but the evidence that I saw suggested that that was a starting point and that patients could continue fairly safely, and I think mainly in the 2 and 3 classes, probably more in the 2, safe exercise at home. We don't know what that was at baseline, but it seems like since there is some physiologic benefit to some patients with exercise, I wonder if you can comment on that, because that's a curiosity that I think seems to need further highlighting. So.
Thanks.
Yeah. Okay.
Yes, Dr. Lin, please go ahead.
Yeah, I just to say we don't have information on what kind of exercise program, if any, people in the trial were on and what they had previously. I think we heard from the clinical experts that while pulmonary cardiac rehab is very helpful, it's often very difficult to access. And so while ideally, I think the guidelines present an ideal situation, in reality, it's not something that, that is easy for every person to access and have as part of their therapy.
Great. Dr. Simon, anything you want to add to that?
Yeah, just to add to that, it's pretty, I would say it's, this is more the rule than not that I've seen in pulmonary hypertension clinical trials, to not report a baseline, exercise program. And I think that's because of the access issues and the difficulty there. I'm trying to think of any trial where I've seen that reported. I can't think of one. To the point about telangiectasias, and an interesting insight with HHT. The telangiectasias, I would say, is something that clinically we've noticed and we have some concerns about, and really a question about what that means long term, and we don't know, and is one of the things we'd like to see in longer term studies, which I'm sure we will, with particularly, if nothing else, from open label studies as we go along. The link with HHT is very interesting, right? So HHT causes arteriovenous malformations and shunting, which in some cases actually can be a cause of pulmonary arterial hypertension. And in some cases, we will treat that. Personally, clinically, I would not reach for this medicine, certainly in early days, for any patient that I knew that had HHT. It also makes me wonder sort of mechanistically if there's some insights to be had there for further research.
Great. Thank you very much. I think Dr. Johnson, you'll be the last question, and then we'll move to the next section.
Okay, I just have a quick question about the disease state. So the population in the main trial had been diagnosed for about 9 years before they were enrolled in this trial. But would you say that like the disease state has a latency in diagnosis like some disease states, or does the pathology create symptoms pretty immediately?
That's a great question. No, there is often a delay, of a significant delay of, I think, up to years, a couple of years, in part because the initial symptoms are very sort of vague and slight. So you might feel a little shorter breath, and it's not immediately obvious that pulmonary arterial hypertension is the cause of that. Dr. Simon, did you want to make any additional comments?
Yeah, it's we bandy about a number of about 2.5 years to get a diagnosis from the time patients present with symptoms. And as Grace said, this is in large part due to the non-specific nature of the symptom, shortness of breath. It gets misdiagnosed a lot of times. I think I saw some comments for the report noting that it may be not related to severity of symptoms. The patients could have severe symptoms, but they're non-specific, and they still are. It takes a while to get to the diagnosis. And this is something we've been trying to fight for years. This long delay to get diagnosis and treatment.
Great. Thank you, everyone. Dr. Lin, thank you very much, and everybody for the great questions. I'm actually, we're a minute ahead and we're tight in time this morning, so I'm going to move ahead and ask Dr. Mill Whittington to present to us about the evidence and economic modeling.
Thank you. Thank you, Dr. Mustafa. Hello, everyone. I'm Mel Whittington. I led the economic modeling within this review. Thank you all for being here today. Next slide. I first want to acknowledge Dr. Marina Richardson, Senior Health Economist at ICER, who led the budget impact modeling within this assessment. We have no conflicts to disclose. Next slide. The objective of this portion of the assessment was to estimate the lifetime cost effectiveness of sotatercept when added on to background therapy as compared to background therapy alone for adults with pulmonary arterial hypertension and WHO functional class 2 or 3 at baseline. Next slide. I'll discuss briefly some of our methods, primarily the key assumptions and model inputs, but there's much greater detail and transparency in our evidence report, so do please check that out. But briefly, to achieve our objective, we created a Markov model from the United States setting and the healthcare sector perspective, where we focused on direct medical healthcare costs and patient health outcomes. We did present findings from a modified societal perspective as a scenario analysis. Our time horizon was that of a lifetime, with all future costs and outcomes discounted at 3% per year. The cycle length was 12 weeks in alignment with the clinical evidence, and our primary outcomes included costs, equal value life years, quality adjusted life years, and years without symptoms at rest, which was defined as time spent in functional class, WHO functional class 1, 2, and 3. Next slide. This slide reports our model schematic, and there's a lot here, so we'll kind of take it piece by piece. I first want you to look at the different ovals, and the ovals represent the health states that were recorded in the model. And as you can see, they're defined by WHO functional class and death. So there's a health state for WHO functional class 1, 2, 3, and 4. You will notice that for functional class 3 and 4, there's actually 2 health states. There's a 3A and a 3B, as well as a 4A and a 4B. This is just presented for extra transparency and for to denote that those individuals were on different treatments. So I'll talk about the treatment differences when I get to the colors, but looking just at the ovals, they're defined by WHO functional class and death. You can also look at the arrows. The arrows show all of the possible transitions between the health states. You'll notice there are forward arrows, so increasing disease severity from WHO functional class 1 to 2, for example. And there are also some backward arrows improving WHO functional class, for example, going from WHO functional class 2 to 1. You will notice those backward arrows are dashed, and that is because they only occur for the first 24 weeks in the model, which I will speak to more on the next slide. And the last thing I want you to take away from this slide are the different colors. The different colors are intended to denote which treatments individuals are on at different health states. So the blue represents an individual being on sotatercept in that health state if they are in the intervention arm. So we see that in WHO functional class 1, 2, and 3A. And then when we get to WHO functional class 4A, you see this blue oval with the green diagonal lines. And those green diagonal lines represent the addition of an infused prostacyclin. So in our model assumption, we assumed that once an individual reached WHO functional class 4, an infused prostacyclin would be added, at which point they could improve back to functional class 3. In this case, we call this 3B because in this case, individuals are on sotatercept and an infused prostacyclin in the intervention arm, or if this is the comparator arm, they're on the double therapy with now an infused prostacyclin. And then the last oval I want to draw your attention to is the green shaded oval. That is WHO functional class 4B. In this case, we assumed individuals would discontinue sotatercept and would be only on an infused prostacyclin in addition to their background double therapy regimen. And I'll speak more to why we assume discontinuation in WHO functional class 4 on the next slide. All right, so let's move to the next slide. Here are our key model assumptions, many of which I've already alluded to a little bit on the previous slide, but can provide a little bit more color to now. The first one, improvement in functional class occurred only over the first 24 weeks. Given the short duration of the majority of randomized controlled trials in pulmonary arterial hypertension, evidence of further functional class improvement beyond a few weeks or few months is lacking. Other economic models in pulmonary arterial hypertension primarily allow functional class improvement for only 12 weeks or the first model cycle for other treatments in pulmonary arterial hypertension. However, given evidence that exists for sotatercept up to 24 weeks, we allowed for the potential for improvement in functional class for the first 24 weeks or the first 2 model cycles. We do acknowledge this is a key model assumption in an area where we are hopeful for additional long-term evidence. And so we do test this extensively through scenario analyses, and I'll present those findings as well. The second bullet, patients who discontinued sotatercept due to adverse events discontinued after the second model cycle. Clinical experts suggested that adverse events leading to discontinuation likely occur relatively soon after treatment initiation, and thus it was reasonable to assume that they occurred over that trial follow-up period. No subsequent adverse event-related discontinuation was modeled after that second model cycle. And then the last key assumption I want to emphasize is that if an individual had been on sotatercept and an infused prostacyclin, which again was added once they reached WHO functional class 4, for more than one model cycle and they didn't improve, so if we think back to that schematic slide, that was what was going on in the far right hand of the screen where they're going from 4A to 4B, or if they had transitioned back to WHO functional class 4 after initially improving once starting an infused prostacyclin. So this was again at the very right-hand side of that schematic, moving down from 3B to 4B. At that point, we assumed they would discontinue sotatercept. So that was that green oval. We made this assumption because given members of the modeled cohort could not worsen from WHO functional class 4, sotatercept would only have an impact on cost. And so we modeled it as discontinuation would occur at WHO functional class 4 after being in there for 1 model cycle. We do test this in scenario analyses and we'll present those findings today. Next slide. I want to talk about a few of the key model inputs, one of which being health state transitions. So how we tracked that cohort through that model schematic was informed for the first 24 weeks, so the first 2 model cycles, were based on transition probabilities directly observed in the STELLAR trial. So the manufacturer provided us these transition probabilities for the placebo arm of the trial and the sotatercept arm of the trial as academic in confidence, and those transition probabilities were used directly in the economic model for the first 2 model cycles. The trial follow-up was only 24 weeks, so we needed to figure out what we are going to do beyond 24 weeks over our lifetime time horizon. And so for the comparator, after 24 weeks, we used the transition probabilities from STELLAR from week 13 to week 24, and we used those over the lifetime time horizon, but didn't allow for any improvement in functional class. And then for the intervention, the manufacturer also supplied us sotatercept's effect on slowing the worsening of functional class as academic in confidence. And so that treatment effect on slowing the worsening of functional class was applied to those comparator transition probabilities for after 24 weeks. The next slide reports, next slide please. The next slide reports our utility inputs used that did differ by WHO functional class. You can see as functional class increases, the utility does go down. Next slide. And this slide reports our cost inputs. Again, there's a lot of information on this slide. So let's take this row by row, starting with sotatercept. Importantly, for all of the results I'm about to show you, this uses a placeholder price of $400,000 per year. And this is purely a placeholder price. A price is not yet known for sotatercept. The next row was double therapy. We assumed that sotatercept would be added on to background therapy, and for everyone, background therapy at a minimum included a double therapy treatment regimen. We use a basket of double therapies, of various double therapies, because there are 9 different double therapy regimens that are commonly used. You can check out our evidence report for a full description of what those 9 regimens are and the price and market share of each of those regimens. But the annual cost for the double therapy included in our model was around $75,000. The next row, we then assumed some individuals as part of background therapy would be on a third therapy, an oral or an inhaled therapy. And evidence suggested around 20% of patients in functional class 2 and 3A would be on this third oral or inhaled therapy. Again, this therapy was a basket of multiple different treatments. Again, check out our evidence report for more specifics, but this basket was around 60% selexipag, as well as some other drugs as well, for an annual cost for that basket of $169,000. Dr. Lin talked about selexipag. So if you multiply 20% times 60%, that's around 12%. So approximately 12% of the cohort was on selexipag as part of their background therapy. And on the bottom row, I already talked about how once an individual reached functional class 4, we assumed a third infused therapy would be added on. There are 2 primary treatments here, and this basket was a mixture of both of those for an annual cost of around $56,000. Again, these double therapy and triple therapies are baskets. Some of these treatments are more expensive than the annual cost, and others are less expensive than the annual cost, but the price used is based on the percentages of the drugs that are reported in the evidence report. Next slide. All right, let's get into our results. This slide shows our base case model outcomes. The first row reporting sotatercept and background therapy, and the bottom row reporting background therapy alone. As you can see from this slide, the total costs were greater for the sotatercept arm, assuming a placeholder price of $400,000 per year. Sotatercept also, in the sotatercept arm, there are also greater life years, greater quality adjusted life years, greater equal value life years, and more years without symptoms at rest. Next slide. Looking at these model outcomes incrementally, the incremental cost effectiveness ratio for sotatercept was around $1.8 million per equal value life year gained, again, assuming a placeholder price of $400,000 per year. Next slide. We conducted a one-way sensitivity analysis to identify which model inputs are really driving the cost effectiveness findings. And so we plot this in this tornado diagram. And from this tornado diagram, you can easily identify that the sotatercept effect on functional class worsening and the utility in the different functional class health states are key drivers of the findings. Now, notably, sotatercept's effect on functional class improvement was not able to be included in the tornado diagram as a single modifiable input because directly observed transition probabilities from the randomized controlled trial was used for that first 24 weeks of the model to capture functional class improvement. So it's not like we had one single input to vary in our one-way sensitivity analysis. Next slide. We also conducted a probabilistic sensitivity analysis. So probabilistic sensitivity analysis is important to vary all of the model inputs across a distribution to be able to assess uncertainty and variability in those model inputs, and then see what it does to the probability of being cost effective. So we ran our model 1,000 different times, and there was a 0% probability of sotatercept being beneath cost effectiveness thresholds of 50,000, 100,000, or 150,000, again, assuming a placeholder price of $400,000 per year. Next slide. This slide reports our scenario analyses. Again, our scenario analyses were selected to test key model assumptions. And so the first row in this table is our base case. So we have our base case incremental cost effectiveness ratio of around 1.8 million per equal value life year gained. We did expand our perspective to a modified societal perspective by incorporating productivity gains as well as caregiver time spent caregiving. And the incremental cost effectiveness ratio from that modified societal perspective was relatively similar, around 1.6 million per equal value life year gained. The next row is where we tested that assumption of discontinuation of sotatercept after being in functional class 4 for one model cycle. In this scenario analysis, we assumed treatment continued until death, and the incremental cost effectiveness ratio was slightly less favorable, around 1.9 million per equal value life year gained. The bottom two rows are where we test some alternative assumptions for functional class improvement and worsening. So in one scenario, we assumed that sotatercept was capable of halting the WHO functional class at 24 weeks. So based on those transition probabilities that were provided to us from the manufacturer, wherever an individual was at the end of the trial, we assumed they stayed there over their lifetime. There was no more worsening, no more improvement. And in that scenario, in that optimistic scenario, the incremental cost effectiveness ratio improved to around 1.2 million per equal value life year gained. And then we looked at one other scenario where we allowed for WHO functional class improvement over the lifetime rather than that first 24 weeks that I previously mentioned. And again, the cost effectiveness improved in this situation to around 1.19 million per equal value life year gained. Again, all of these results are assuming a placeholder price of $400,000 per year. Next slide. This slide reports ICER's health benefit price benchmarks for sotatercept. Now, due to sotatercept being added on to background therapy drugs that are costly, I showed this on the cost input slide when we talked about the double therapy and the third therapies. There was no positive price that could meet thresholds of $100,000 or $150,000. So in alignment with ICER's reference case, when no positive price can be found cost-effective, we present here the QALY-based and EVLY-based threshold analysis results that excluded all non-intervention costs, so excluded background therapy costs and health state costs. Next slide. A few limitations are important to note. We have controlled trial evidence for sotatercept for 24 weeks. And the long-term cost effectiveness of sotatercept is going to be dependent on the long-term effectiveness of sotatercept on improving functional class or slowing the worsening of functional class. However, even under the optimistic assumptions taken in the scenario analysis, one of which we did assume allowed for improvement over the lifetime, if priced at a placeholder price of $400,000 per year, sotatercept would still exceed typically used thresholds. On the second bullet, there's limited evidence on sotatercept's independent effect on mortality or on functional class transitions when added on to an infused prostacyclin. Next slide. We are grateful for the number of public comments we have received. I will mention a few here. The first was to allow for transitions to non-adjacent health states per model cycle. So if you think back to our model schematic, the arrow was going from, say, 3 to 2. There wasn't an arrow going from 3 to 1. In conversations with, so we only modeled adjacent health states, not non-adjacent health states. And this was informed by conversations with clinical experts. We heard that transitions to non-adjacent functional classes within our 12-week model cycle are very unlikely. And those that have been reported in the literature or data were likely right on the cutoff line and are more reflective of a one-step change rather than a two-step change when you're considering outcomes. Further, using the academic and confidence data provided by Merck, the number of patients that transitioned to non-adjacent health states was very, very small and was observed in both arms. The second bullet here was a comment about defining our health states by risk strata rather than by WHO functional class. So our model did use the commonly used WHO functional class to define the health states. The manufacturer's population health model did use the more recent risk strata to define their health states. However, when we make similar assumptions as the ones that were made in the manufacturer's model, even though ours is defined based on functional class and theirs was defined based on risk strata, when we make similar assumptions to what they used, our model findings are very similar, suggesting that having health states defined by risk strata or WHO functional class probably doesn't dramatically influence the findings. And the last comment was to include an independent effect of sotatercept on mortality. We've already spoken to this a little bit today, but we assumed in the results that I just reported that sotatercept reduced mortality through its effect on functional class. So you still saw that there were life years gained in the sotatercept arm, and that was driven by sotatercept's modeled effect on functional class. We did not assume an additional independent effect of sotatercept on reducing mortality, and that has not been proven in the trial data that we do have. Now, the manufacturer did model a 75% reduction in mortality in their population health model, but we did not model this as an independent effect in our model due to a small sample size, short time frame, a potential for double counting with the mortality benefits downstream of functional class improvement, and the 75% reduction was not statistically significant. Next slide. So to conclude, our model suggests sotatercept does produce improved clinical outcomes. At a placeholder price of $400,000 per year, sotatercept would exceed commonly used thresholds, and these findings will be primarily driven by the effectiveness of sotatercept on improving functional class and on slowing the worsening of functional class over the long term. Next slide. And with that, I think we can take questions.
Great. Thank you so much, Dr. Whittington, for this really excellent presentation. Very clear. I'm going to start with a clarifying question, and then I see other hands up too. If I noted correctly on the framework where you showed us the assumptions of the models, there wasn't a backward arrow from class 4. Did we assume that patients with class 4, once they get there, it is very hard that they improve in WHO class?
Great point for clarification. We assume that they could only move backwards from 4 to 3 due to the effectiveness of the infused prostacyclin. So the improvement from, say, 3 to 2 or 2 to 1 in our base case was only over the first 24 weeks, but an individual could improve from 4 to 3 at any point after they first have been added on an infused prostacyclin. So assuming that, okay, an infused prostacyclin's added, there could be some additional improvement. But we did not assume that sotatercept had any independent effect on that improvement, that improvement was just that of the infused prostacyclin.
Okay, thank you for the clarification. Dr. Falkjaer.
Just real quick, where did Merck get the data that they could assume a mortality reduction? I'm confused.
I'll jump in on that, I guess. So there were a handful of deaths on the order of 6 or 7, depending upon what time frame you're looking at in the placebo arm, and on the order of 2 in the intervention arm. And they modeled a hazard ratio of 0.25, which led to an 11.4-year increase in life in the intervention arm.
Yeah, super sparse data. Thank you.
Thank you. Dr. Martin.
Well, and thank you for the presentation. I have I guess a 2-part question. One is if you can kind of characterize the validation studies. There was mention of an evidence report, but there wasn't the data in terms of how close your model got to the other targets or other data. Then a second, more focused question related to that topic. When I compare the Merck model with your model, we get an unadjusted survival difference. Yours is about 4.2 life years. Theirs is 5.1. I wondered if you can articulate what's driving that difference. You mentioned they were pretty close, but some may argue, a 20% difference in survivals, kind of close, but not really that close. So if you can kind of go into what may be driving those differences, because that could have impact on the models when you apply those ratios to, higher baseline survival, you get difference. Not that it's going to make any difference in, at the placeholder prices. I recognize that.
Absolutely. I'm going to start with the second part because I think that also kind of answers the first question as well related to validation. I was overjoyed to see that there was a model put out by somebody that's not ICER, because that allows us a great opportunity to validate our model. So the population health model done by Merck made 2 optimistic assumptions that our model did not in its base case. And that was assuming improvement in functional class could occur over the entire lifetime at the same rate as what was observed from week 13 to week 24 in the trial. We didn't include that in the base case. We did do that in that bottom row of the scenario analysis table I talked about. The second assumption was that sotatercept had an independent effect on mortality using a hazard ratio for all-cause mortality of 0.25. Okay. Now, when we take our model and we assume those two assumptions in our model, which we didn't assume in our base case, when we do that, our model generates very similar findings as the published population model. So modeling both of those optimistic assumptions, our model produces 4 life years in the comparator arm and 15 life years in the sotatercept arm. So 11 life years gained. Their model with those two optimistic assumptions reported 11.5 life years gained. So that suggests to me pretty good validity between the two models, even while there are other differences in modeling exists, theirs was based on risk strata and ours was based on functional class. Now, interestingly, the second assumption, the one related to the independent effect on mortality, that by far had the largest impact on the difference between their published population model and our base case findings. When we only model that first assumption that, hey, is this improvement in functional class, does that occur over the lifetime rather than the first 24 weeks that you assumed in your base case? When we do that, when we make that assumption, it results in 2.45 life years gained, far less than the 11 years gained that happens when you incorporate the mortality assumption. So I think the big difference between our model and their model is really driven by that independent effect on mortality.
Yeah, I guess I wanted to, if we could focus on the background, because I think the evidence report articulates very well the differences in those assumptions, which, one might argue is a heroic assumption on that kind of mortality benefit. But on that background therapy, looking at 5.1 versus 4.2 years, it's still a pretty appreciable difference between your model and their model. Do you think that's being driven by they use risk strata, you're using WHO functional class? Do you think that, and, in I guess the placebo arm or the background therapy arm, excuse me, they're allowing also those transitions a durable effect?
Sure. Yeah.
That's what's driving that. I'm just trying to kind of understand that on the background therapy only arm.
On the background therapy, yeah, you're exactly right for pointing that out. It could be a variety of different things. It could be difference in underlying all-cause mortality data used. I tend to focus on the incremental difference because that's what's driving the actual incremental cost effectiveness ratios and the health benefit price benchmarks. That incrementally, we really want to be quite close. And because that's where we're looking at the differences between the treatment and background effect. But yes, I do think our magnitude was slightly different, and that could be due to the things that you mentioned, but as well as just a different source and background mortality.
Okay, great. I'm not seeing any other hands up. But maybe I'll just very quickly make sure that we touch base with our patients and patients' representatives, Julia and Katie. Based on what you heard, is there anything you want to point out? And I'm sure more to discuss when we hear from the public commenters.
I don't have anything for this section. Thank you for the opportunity. There was one perhaps comment on the previous section, if I might discuss from patients' perspective on the questionnaires and their response to improvement in quality of life. I happen to be one of the patients who filled out the questionnaires, and I know that the questionnaires are standard that were created for this type of purpose, but when I was filling it out, I was not pleased with them in the way that they were created, in that for 2 reasons. The first one is I've had PH for so long. When I was first diagnosed, I was functional class 4, and I've since, even before sotatercept, I was brought back to functional class 2. And so when I answered the questionnaire to begin with, my answers were based on how bad I know I could feel with pH versus how I felt that day. And so the numbers were perhaps not as high as they might have been if I had not been as sick at the get-go. And then at the end of the 24 weeks filling out again, I was not provided what my answers were at the beginning, which I know is by design. But I had to guess, try to remember what my answers were versus what I felt. Because the number scale was such a short number, there wasn't much room for variation in how the improvement was. And so that may play a factor in more patients than just myself for why the responses weren't as overwhelming as they had hoped.